Hello, I'm Peter Kistler for Heart Rhythm TV, and it's my great pleasure and honour to have Dr. Jason Andrade with us at FHRS 2023. Jason's from Vancouver and really has been at the forefront of a number of recent trials looking at the role of AF ablation, and I thought we'd really try and drill down on what we should be looking at as our primary endpoint for efficacy of all interventions in AF outcome trials. What are your thoughts?
So I think there's different perspectives, and part of the difference in those perspectives is the goals of what we're trying to achieve. So if we're looking at it from a patient perspective, really it comes down to clinically meaningful recurrences, so things that they're aware of, things that are impairing their quality of life, things that are driving them to healthcare utilization like emergency room visits and hospitalizations. Payers are going to look at it from the healthcare system costs, so how much are these interventions costing them versus the money saved in terms of those saved hospitalizations and emergency room visits. And then if we look at it from a purely scientific, technological perspective, we want to know that the interventions work in terms of arrhythmia efficiency. Balancing those three different perspectives, I think, is where we need to be. We need to maintain comparability between studies, so a universal definition becomes important. But the problem is 30 seconds of atrial fibrillation, as kind of defined many years ago, doesn't translate out into those quality of life outcomes. It doesn't translate out into those healthcare utilization outcomes, so it becomes a bit meaningless.
You recently showed in your paper in the European Heart Journal some really lovely Cutpoint data for us. Would you like to share that with us?
Sure. So what we did is, using loop recorder data like we had in Circadose, we could get a very granular look at how long the AF episodes were going. We could look at it from burden, so the time that patients were spending in atrial fibrillation, versus the longest episode duration. And what we showed is that there seemed to be an inflection point where quality of life was affected, where healthcare utilization was affected, when the burden in a post-ablation paroxysmal population was greater than 0.1%, or if the episode durations were longer than about 1 or 6 hours, depending on where you want to draw your line.
I'd like to draw you out a little bit on AF burden. I suppose I feel like we're moving towards burden from a single defined duration episode. And just some of the things I've been struck by with burden is this concept of mean versus median, because obviously the data's skewed when we look at recurrence after AF, and those numbers can get pretty small. Like with Circadose, it's kind of interesting that it was 0%, and even with Kepler, which we recently published, our AF burden was 0 versus 0. I wonder then, when we take it to a more general audience and we're saying we're comparing two interventions, both of which give us a 0% AF burden, how we kind of reconcile that, how you think we should use that?
Yeah, I think there's two parts to that conversation. So the first is, clinically, even non-electrophysiologists use the concept of burden, right? When we assess a patient in the office, we're asking them how much atrial fibrillation they're having. Are you having a little? Are you having a lot? That's just a very broad concept of burden. Burden, as we discuss it, is what the loop recorder is recording, how much atrial fibrillation they're having. That gives us a very objective way, quantitative way of understanding it. The problem that I've struggled with in terms of using burden clinically is it's very much dependent on your window of observation. And so to use a burden on a very small window of observation, if someone's in an AF episode, their burden's 100%. If they have one episode a month, their burden is 3%. It differs a lot based on what we're seeing. And I think that's why post-ablation, most burdens are mostly 0. But the person who has 24 hours of AF over 6 months could be profoundly affected by it. That could lead to a hospitalization or an emergency room visit, even though the burden number is small. And so trying to figure out how to integrate some assessment of burden, maybe it has to be over your burden in the last 3 months as opposed to your burden in the last 3 years. How are we actually going to operationalize the assessment of burden as an endpoint to understand it better?
So when we come to talk about burden, obviously an implantable loop recorder is the gold standard. What do you think the minimum requirements are if we're looking at randomized trials for surveillance for AF after an intervention?
So, the partner paper that we had to that European heart paper was one we published in Circulation earlier in the year. And basically what we did was try to figure out the accuracy of non-invasive rhythm monitors for determining burden. And so if our focus is on burden, you can get away with 3 7-day monitors over a year.
Okay.
So about 21 to 28 days of monitoring will give you roughly a 90% correlation with the burden. The problem is the less you monitor, the more you overinflate the burden. And so you overestimate burden with 24-hour holters, to a lesser extent with 48, to a lesser extent with 7 days.
Okay.
So if our focus is on burden, if we're really going to use non-invasive monitors, at least 21 to 28 days over a year. But really, the only true assessment of burden is an implantable monitor.
And in terms of primary endpoints for upcoming trials, what are you using? And I suppose we've suggested that should be AF burden, but what about quality of life?
I think that probably the most meaningful endpoint is going to be some integration of those things.
Yeah.
So you could look at it as, you could call the combined endpoint clinically meaningful atrial fibrillation. So if someone has a symptomatic recurrence, that's by definition meaningful to the patient. If they have asymptomatic recurrences in combination with symptomatic recurrences, it's a matter of finding the line where that matters. Is that 6 hours because that's what's associated with hospitalization? Is it 24 hours because that's what ASSERT associates with stroke? I think it's probably going to be a combination of some symptomatic episode with some asymptomatic duration or burden, and that will become your arrhythmia endpoint. But I think that all studies need to assess arrhythmia endpoints in combination with patient-reported outcomes, so quality of life, and ideally also should be looking at healthcare utilization in concert and have all three together.
Yeah, great. All right, well, thank you very much for your time, Jason. Been a pleasure.
No problem. Thank you for having me.